Hi, Dr. Teplinsky. Welcome to MD Newsline. Thank you so much for joining us. Can you please introduce yourself to our audience?
Thanks so much for having me. I'm excited to be here. I am Dr. Eleonora Teplinsky. I'm a breast and gynecologic medical oncologist at Valley Health System in New Jersey and a clinical assistant professor at the Icahn School of Medicine at Mount Sinai.
Thank you so much. So we're here at ASCO, and there's a lot of exciting research and insights being shared. And I just want to know, what are some of the top insights and announcements that you've heard here at ASCO?
This has been a big meeting for breast cancer, and really the main updates have been in metastatic breast cancer. And there's really three big studies. There's others, of course, but there's kind of three big studies that everyone is talking about, and they're in hormone receptor positive, HER2 positive, and triple negative. So we can certainly break those down a little bit.
I'm trying to remember the title of the SERENA-6 trial,
Yes.
right?
So yeah, we can start with that. That was a plenary. So, big study also published simultaneously in the New England Journal of Medicine. So the SERENA-6 trial, what that does is patients with hormone receptor positive, HER2 negative metastatic breast cancer in their first line therapy with an aromatase inhibitor and a CDK4/6 inhibitor. And what they really asked in this study was, normally we wait for disease progression on imaging to change therapy. And they said, well, what if we test for ESR1 mutations early and change therapy before we see disease progression on scans? What is that going to do with the outcomes? So they had their patients, again, had to be on first-line endocrine therapy for at least 6 months. And then they were randomized they entered the study and they underwent screening for an ESR1 mutation via a liquid biopsy. For any patients, that is a blood test. And they did that every 2 to 3 months on the study, and they screened over 3,000 patients, and they detected ESR1 mutations in kind of around 550 patients around there, and about 350 were randomized. So once they detected the mutation, if they had no progression on imaging, they were randomized to either continue what they were doing, so continue on the AI and the CDK4/6 inhibitor, or switch the aromatase inhibitor to Camizestrant, which is an oral SERD, a selective estrogen receptor degrader that's going to overcome, we think, the ESR1 mutation. And they continued on the same CDK4/6 inhibitor. So think of this really as an early switch approach before we see progression on imaging. And primary outcome was progression-free survival. And they showed that the median progression-free survival in patients who stayed on their treatment was 9 months compared to 16 months in patients who switched, translating into a 56% reduction in the risk of progression or death. So obviously this is really exciting, but there's certainly several concerns that, come up, right? So the first is Camizestrant is not yet FDA approved, so that's, we can't use this. It's not something we're going back to the clinic and doing tomorrow. What is going to be the cost of these tests, right? They did them every 2 to 3 months. If Camizestrant is approved, right, we think we'll have some guidance on cost and coverage, but what's, in this study, they did it every 2 to 3 months is, what's going to look like that in clinic? Are we going to do that every 2 to 3 months? Is it going to be less frequent? What is the right cadence? And so those are big concerns. And of course, we don't have overall survival data. We don't have PFS2 data. So what happens after that second progression? Because, the question that's been raised is, are we just switching earlier and delaying the progression? And would you have the same outcomes if you just crossed over and switched to Camizestrant at time of progression? Or are we really impacting long-term survival? And so those are all still questions that we don't have the answers to. And in terms of side effects, Camizestrant does have some side effects: anemia, neutropenia, some GI toxicity, joint pain, back pain. It can cause bradycardia, photopsia, dry eyes. The rate of discontinuation was very low, it was 1.3%, but and in the study they did show a decrease in the median time to deterioration of quality of life, an increase, so the more improved quality of life. But I think that there's still a lot of questions that remain, and we'll see what happens and as more data comes out, but really exciting. And I think really a novel approach of starting to look at this utilizing liquid biopsies, thinking, can we intervene before we see disease progression? And only time will tell what that really looks like.